Assalamu alaikum warahmatullah. Welcome to our lecture in our radiology course, completing the chest X-ray session, starting with part of 1/4 of how to read chest X-ray. First, we start with checking the identity of the patient, his age, check the patient name. Above all else, make sure you are looking at the correct chest X-ray first. This sounds obvious, but when you are stressed and under pressure, you can skip some of the basics. If you have the wrong X-ray, you will be wasting time, not saving it. This is the first part. The second part, that look up the patient history, because you need to correlate patient history with the chest X-ray you have. When you are preparing to read an X-ray, make sure you have all the information on the patient, including age and sex and their medical history. Remember to compare with old X-ray if there are any. The third point, that read the date of the radiograph. Make a special note of the date when comparing older radiograph. Always look at older radiograph if available, because we need to compare regarding the patient situation, if he is improving or deteriorating. The date the radiograph is taken provide important context for interpreting any finding. Starting with our first quiz from the last session. True or false? Old X-ray are outdated and won't generally provide useful information on the patient. What do you think? This is definitely false, because the old X-rays give us previous history of patient situation. Then check if the film was taken under full inspiration. Chest X-ray are generally taken when the patient is in inspiratory phase of the respiration cycle, in layman terms, having breath in. This has an important effect on the quality of X-ray. When the X-ray beam passes through the anterior chest onto the film, its rib the closest to the film, the posterior ribs, that are most apparent. You should be able to view 10 posterior ribs if it was taken under full inspiration. Remember, when we check the quality of the X-ray, we should remember that full inspiration is crucial in chest X-ray, and we make sure by counting the rib from 8 to 10, anterior rib is adequate inspiration. If you can see 6 anterior rib, then the film is of a very high standard, so we don't use it. Then check the exposure. Overexposed films look darker than normal. When we said that overexposed film looks like very blackened or blacked out, and fine detail are very difficult to see. Underexposed film look whiter than normal, and it may mimic pathology, although the patient is normal, but these are quality factors. Underexposed film look whiter than normal and cause the appearance of area of opacification. Look for intervertebral bodies in the properly penetrated chest X-ray. We should only see the vertebral column without details in good exposure. An underpenetrated chest can't differentiate the vertebral body from the intervertebral spaces. It is underpenetrated if you can't see the thoracic vertebra. An overpenetrated film shows the intervertebral spaces very distinctly. So we use the spine in chest X-ray to make sure is it under-penetrated, well-penetrated, or over-penetrated. Should be well seen without details of the disc spaces. Then check for rotation. If the patient wasn't completely flat against the cassette, there may be some rotation evident on the X-ray. If this has happened, the mediastinum can look very unusual. You can check the rotation by looking at clavicular heads and thoracic vertebral bodies. Check that the thoracic spine align in the center of the sternum and between the clavicles. This is regarding rotation. The second quiz, how can you tell if the film was exposed probably? Is the option, the X-ray will be on the whiter side, intervertebral spaces will appear very distinct, thoracic vertebra will be visible, the X-ray will be on darker side. So I let you to answer this quiz. Moving to the third part, identifying and aligning the X-ray. Starting by picking up the chest X-ray in the right way, so the clavicles above and the diaphragm and upper abdominal organs like liver or gastric gas bubble on beneath. Look for marker. The next thing is to identify the position of the X-ray and align it correctly. Check for the relevant marker printed on the radiograph. L stands for left, R stands for right, BA for posterior anterior, AB for anterior posterior, extra. Note the position of the patient. Is it supine, meaning lying flat, or upright, standing, lateral, decubitus, that means the patient lying on his side. Check for and mentally notate each side of the chest X-ray. This is so important because when you mix the right as left or the left as right, then you can falsely interpret an image. Then position the posterior anterior and lateral chest X-ray. Normal chest X-ray will consist of both BA and lateral films. This is the routine films done for a patient, which are read together, aligning them so they are viewed as if the patient were standing in front of you, so their right side would be facing your left. If there are old films available, you should hang these adjacent. The term posterior anterior refers to the direction of X-ray traversing the patient from posterior to anterior, from back to front, as we have seen before. The term anterior posterior refers to the direction of X-ray traversing or cutting through the patient from anterior to posterior, from front to back. The lateral chest radiograph is taken with the patient left side of chest held against the X-ray cassette. So, in lateral chest radiograph, this is important. The patient left side of the chest against the X-ray cassette or the film. So, always the X-ray beam cut the patient from his right side toward his left side in lateral chest radiograph. An oblique view is a rotated view in between the standard front view and lateral view. It is useful in localizing lesions and eliminating superimposed structures. This is a special views, we need it in some times. Then recognize an AB anterior posterior X-ray. Sometimes AB X-ray are taken, but usually only for patients who are too ill to stand up straight. For the posterior anterior X-ray, as we said before, like the patient in the intensive care unit or ICU, we can take the X-ray as portable X-ray in AB position. AB radiographs are generally taken at shorter distance from the film compared to BA radiograph. Distance diminishes the effect of beam divergence and the magnification of structures closer to the X-ray tube, such as the heart. Since AB radiographs are taken from shorter distances, they appear more magnified and less sharp compared to the standard BL films. An AB film can show magnification of the X-ray and a widening of the mediastinum in AB, unlike the BA film as we have seen before. This is the lateral decubitus film. The lateral decubitus film, the patient lie on his side. Determine if it is from a lateral decubitus position. An X-ray from this view is taken with the patient lying down on the side. It helps to assess suspected fluid like pleural effusion because fluid always go to the gravity direction, and demonstrate whether the effusion is located or mobile, if it insisted in certain area, or it can manipulate with patient motion or patient position. Sometimes fluid in an X-ray can mimic pathology like densities, consolidation, or mass. When you use a lateral decubitus film, then you can differentiate between the types of pathology. You can look at the non-dependent hemithorax to confirm a pneumothorax, which means the presence of free air in the hemithorax, which is an emergency in the chest. The dependent lung should increase in density. This is due to atelectasis. Atelectasis means the collapse of some of the alveoli of the lung from the weight of the mediastinum putting pressure on it. This means atelectasis means collapse. If this doesn't happen, it is an indicator of air trapping. That means the air can't move out to let the alveoli to collapse or atelectasis take place. Moving to the next, align left and right. If we have a chest X-ray like here we have marked with L in left side, we can make sure of the left side from the gastric bubble where this doctor is pointing here. Align left and right. You need to make sure you are looking at in the right way. You can do this easily and quickly by looking for the gastric bubble. Gastric bubble means the presence of the air in the fundus of stomach, which is normal finding. The bubble should be on the left. Assess the amount of gas and location of the gastric bubble. Normal gas bubbles may also seen in hepatic and splenic flexure of the colon, which are the two sides of the transverse colon, because the spleen is adjacent to the gastric bubble and the liver on the right side. So the splenic flexure on left, the hepatic flexure on right, and both are the sides of the transverse colon joining the ascending and descending colon. Our third quiz, why might a patient have AB or X-ray taken? The options are: the patient is too sick to stand up straight, the X-ray need to display sharper details to verify whether the patient's lungs have any fluid, the patient can't rise from a supine position. So you are free to answer this quiz. Part 4, the last part in this section, how to read the chest X-ray, analyzing the image. This is the role of you as the referring doctor who performed or request the chest X-ray for the patient to assess his situation. Start with a general overview before you go on to focus on the specific details. Starting with general overview. It's good practice to take an overview. The major things that you might have skipped over may change the baseline normals you adopt as reference point. Beginning with this overview may also sensitize to look for particular things. Technicians often use what is called the ABCD method, which is check airway, then pulse, cardiac fluid, diaphragm and lung field, and everything else is E, and we are as doctor also use it. Starting with metallic density, one of the 5 density, which is the most whiter one. Check if there is any instrument such as tubes, IV lines, EKG leads, ECG leads, pacemaker, surgical clips or drains. Then check the airway, starting with the trachea, then the bronchi, then the hyla, then the lung field bilaterally. Check the airway. All of these are the components of the airway. Check to see if the airway is patent and midline or shifted to one side or collapsed. For example, in a tension pneumothorax, which is an emergency, the presence of air within the thoracic cavity lead to collapse of the lung and difficult breathing of the patient. The airway is deviated away, which is the trachea is deviated away from the affected side because of the pressure within that side push the trachea to other side. Look for carina where the trachea bifurcate. The carina is the wire the trachea bifurcate into 2 bronchi, right and left. Main stem bronchus or bronchi. In case of fractures, check the bone, look for any fracture, lesion or defect. Note the overall size, shape and contour of each bone, density or mineralization. Osteopenic bones look thin and less opaque. Cortical thickness in comparison to modality, cavity, trabecular pattern, presence of any erosions, fracture, lytic or plastic area. Look for lucent and sclerotic lesions. All of these you should notice in a chest X-ray. A lucent bone lesion, lucent means less dense or more blacker, but the normal bone is more opaque or white, radio opaque or white. A lucent bone lesion in an area of bone with decreased density appear darker. It may appear punched out, means like a hole within the normal bone to surrounding bone. A sclerotic bone lesion is an area of the bone with an increased density in comparison with the adjacent normal bone. At joints, look for joint spaces, narrowing, widening, calcification in the cartilage, air in the joint space, and abnormal fat pads. Then we move to the soft tissue. After looking in the airway or lung fields, then to the soft tissue. Soft tissue, check the diaphragm. The diaphragm is the muscle that separate the thoracic cavity from the abdominal cavity. Look for a flat or raised diaphragm. If it is flat, that means the thoracic cavity pressure is increased, so let the diaphragm setting downward. If it is bulging or raised diaphragm, means that there is some pathology within the abdomen that make the diaphragm upward, or any defect in the diaphragm nerve supply, because the diaphragm itself is muscle. A flattened diaphragm may indicate emphysema presence of more cystic areas of air within the chest. A raised diaphragm may indicate area of airspace consolidation, as in pneumonia, making the lower lung field indistinguishable in soft tissue density compared to the abdomen. The right diaphragm is normally higher than the left diaphragm with almost 1 centimeter due to the presence of liver below the right diaphragm. Also look at the costophrenic angles in the both sides of the chest x-ray, which should be sharp. From its name, costophrenic. Phrenic stands for diaphragm, costo the ribs or the costal ribs. So costophrenic angle is the area with V shaped between the diaphragm and the ribs or the lower ribs in both sides of the chest, which should be sharp for any blunting or obliteration, which may indicate effusion as fluid settles down, because it is the most deeper area within the chest. Here, look at the marker, the area of the costophrenic angle where the fluid can settle down. Then check the heart, examine the edge of the heart, the silhouette margin. When we speak about silhouette sign that when we can markedly and sharply draw the outlines of the heart. Silhouetting means that this margins is not apparent anymore. This is regarding the silhouette. When we say silhouette, means some area or pathology obscuring the margin. Again, check the heart, examine the edge of the heart. The silhouette margin should be sharp, observed whether a radiopacity is obscuring the heart border in the right middle lobe and left lingula pneumonia. For example, also look at the external soft tissue for any abnormalities. A heart with a diameter greater than half thoracic diameter is an enlarged heart, as we have seen before in cardiothoracic ratio, which shouldn't be exceed 50%. Note the lymph nodes in the mediastinum. Look for subcutaneous emphysema, air density below the skin, and other lesions. Check the lung fields. Start by checking asymmetry and looking here regarding the heart and the silhouette sign. Then check the lung field. Start by checking symmetry and looking for any major area of abnormal lucency or density. Try to train your eyes to peer through the heart and upper abdomen to the lung posterior. You should also be examining for vascularity, because in the mediastinum we have the thoracic aorta ascending and descending and the aortic arch, and presence of any mass or nodules within the mediastinum. Examine the lung field for any infiltration, fluid or air bronchogram. If fluid, blood, mucus or tumor extra fills the air sac, and lung will appear radiodense or bright with less visible interstitial markings. The next, the hyla. Observe hyla bilaterally. Look for nodes and masses. When we speak about hyla, means that the area where the great vessels coming from the mediastinum or the heart toward the lung, like the pulmonary veins and pulmonary arteries. This is the area of the hyla, and we have two hyla, the right and left. The left hyla is above the level of the right hyla. Again, observe the hyla, look for nodes and masses in the hilum of both lungs. On the frontal view, most of hilum shadow represent the left and right pulmonary arteries, The left pulmonary arteries is always more superior than the right, making the left hilum higher. Look for calcified lymph nodes in the hilum, which may be caused by an old TB or tuberculosis infection. We have another and last quiz for this section in how to read an X-ray. How can you tell if a bone has a loosened bone or lesion? It will appear whiter, or it will look thin and less opaque. It will have an increased density. It will be darker. Okay, the solution for this quiz that a loosened bone lesion will look thin and less opaque than the other adjacent normal bone. Now moving to the next. Now let's visualize some animation regarding the chest X-ray and its reading. Okay, you are in the exam and in OSCE exam. We bring this chest X-ray to you and we need you to note the anatomical position and the type of chest X-ray, and we ask you to read this chest X-ray. Starting with the loosened line in the midline, this is the trachea, which animated in blue. The trachea descends to bifurcate into the right and left bronchi or main stem bronchus in the angle of the carina. Okay, this is the loosened trachea and divided into two sides, right and left bronchi. If we notice here, the right bronchus is superior than the left bronchus and more wider. Again, this is the trachea and these are bronchi, right and left bronchus. Then we move to the mediastinum. The mediastinum include the blue line, the blue color, the green color, the yellow color, and the red color. All of these soft tissue density, these are the mediastinum area, the midline of the chest in between the both lungs, right and left lung. This is the mediastinum. All of this. The mediastinum has the aortic knob because the thoracic aorta is here. Let's move the label. This is the mediastinum, the aortic knob, the heart, okay, and the bifurcation of the carina and the hilum. The hilum, as we said before, the hilum is the area where the pulmonary vessels exit the mediastinum toward the lung or from the lung to the heart, back if there are pulmonary veins. The arteries going from the heart to the lungs. The veins come from the lungs to the heart. This is the mediastinum. If we saw below, this is the diaphragm. Below each lung, this is the diaphragm with the purple color. This line is the diaphragm. We can notice here the left heart, the left side with the gastric bubble and splenic flexure gas within the colon. This regarding this image. We have a short quiz starting with a question. Determine if the film is AB or BA, supine or upright. AB will make the heart appear larger, among other things. Okay, so this is PA chest radiograph. Here, and ensure adequate inspiration, we have to count the ribs. Up to 6 is suboptimal, more than 6 is optimal study. Here the question was assess for rotation by making sure the medial clavicles are equidistant from the supine columns. Ensure trachea is midline. You have to ensure the trachea is midline, not going toward right or left side. And also if there is a foreign body or no, with metallic density. Here check ribs, clavicle, scapula, humeral heads in the shoulder joints bilaterally, and spine for signs of fractures. Here we scan the bone. Here make sure that you have not cardiomegaly in this study by measure the cardiothoracic ratio. The heart shouldn't exceed 50% of the width of the thoracic cavity on PA radiograph. Examine the left and right borders of the heart and ensure that they are well defined in case of normal silhouetting of the heart. Make sure the diaphragm border are clearly seen and that there is no diaphragmatic flattening. Make sure there is no free air directly under the diaphragm. Here the gastric bubble we mentioned before. Here the colonic air within the splenic flexure on left side, and if there is free air under diaphragm, this is an emergency indicating that there is viscous organ rupture or perforation. Here the costophrenic angles in the junction between the diaphragm and the ribs in the thoracic cavity. Examine both costophrenic angle. They should be sharp and clear, not obliterated with any opacification. Then examine the lung for interstitial, linear or nodular or alveolar like fluffy opacities, masses or consolidation. Okay, this is the normal lung density and this is the lung field. Here we have the pleural line. The pleura is the anatomical coverage like the peritoneum in the abdomen. We have pleura in the chest. The pleura have two layers, visceral pleura and parietal pleura. Also like the peritoneum in the abdomen, the visceral peritoneum and parietal peritoneum. The visceral pleura that cover the lung adjacent to the lung, and the parietal pleura that cover the thoracic cavity from inside. Examine the lung for a gap between the chest wall and lung parenchyma indicating a pneumothorax. The presence of free air in the thoracic cavity is an emergency called pneumothorax. Check for normal aortic knob, contour and widened mediastinum. In some elderly patients, you can find this aortic knuckle calcified or there is calcification within it, which is sometimes is a normal finding, isn't pathology. Check hilum for masses and lymphadenopathy or calcification. The thymus is present in children, thymus gland, which is a normal mediastinal structure type of the lymphatic glands. Then the last thing here, that sometimes you can find extra devices within the patient like endotracheal tube, ET tube. It should be in its normal position. The normal position for endotracheal tube from 3 to 7 centimeter. It always should be above the carina. If it descend to the right or left bronchi, then it is wrongly situated or displaced. Central line, which is here in green color, central line, and in superior vena cava okay, or at the cavo-atrial junction between the superior vena cava and the right atrium. This is the normal position. If it is above or below, then it is misplaced. We have in purple color the NG tube going from the oropharynx, from the patient nasopharynx, oropharynx, then the esophagus, below down to the gastroesophageal junction and set it in the stomach lumen. Check proper position of endotracheal tube, NG tube, and central line if present. All of these can be appreciated from a chest radiograph. Now let's move from the normal chest X-ray to the pathological chest X-ray, starting with the first and the most important emergency in chest, the pneumothorax. In theory, tension pneumothorax presentation, a tension pneumothorax form when air can enter the pleural space but can't escape. The pneumothorax can eventually build up to the point where it compresses the vena cava, impairing blood flow to the heart and thus leading to shock. Patient present with shortness of breath or in cardiac arrest, usually following trauma. On physical exam, there will be hyperresonance in auscultation or percussion of the affected lung, high jugular venous distension or pressure, absent breath sound on the affected side, and deviated trachea on each side, either right or left. What should we see in chest X-ray in cases of pneumothorax? X-ray finding: do not get an X-ray in an unstable patient. So the patient can't take his breath, then you ask him to go and do a chest X-ray. This is wrong because the patient can die while he's doing his chest X-ray, which is fatal. Suspect of having tension pneumothorax. This is a clinical diagnosis. We don't proceed to chest X-ray in pneumothorax. We starting with urgently managing the patient if it is suspected without requesting a chest X-ray. But in X-ray on plain film, the trachea and mediastinum will be shifted away from the inside of the pneumothorax. Additionally, the lung on the side of the pneumothorax will be collapsed. The pleural line will be visible a significant distance from chest wall, and in between the two will be empty space with no lung markings because the air interrupted between the chest wall and the air and the lung. Okay, here we have the normal side. Here the lung is well aerated. Okay, here we have more lucency, which means this is the lucency of the air intervening between the chest wall and the lung. Here we have the collapsed lung, and this is the chest wall. So we call this the pleural or the visceral pleural line. This line is the visceral pleural line. This is the diagnostic sign for the pneumothorax. Here we have the labels: the green air, which is air-filled pleural space. Here a collapsed lung with its margins are the visceral pleural line, and the mediastinal structure is shifted toward the right side because the increased pressure within the left side. And also we have deviated trachea from its normal midline or slightly to the right, going more into the right direction without labels. Here we have what we have seen without labels: the air within the left chest pushing the mediastinal structure to the right side. This is it. Regarding the management of the tension pneumothorax, emergency needle decompression in the second intercostal space at the mid-clavicular line, followed by a chest tube in the fourth intercostal space at the mid-axillary line. A rush of air with needle insertion indicate that decompression has obscured or occurred. When we insert the needle in its place, we call it His sign, because we can hear the sound of the air gush outside the chest. Okay, here the normal, here a pneumothorax with labels. Moving to the next pathology, which is an open pneumothorax. This is tension pneumothorax because we have no opening, just collapse with air within, going to open or open pneumothorax. The difference between tension pneumothorax and open pneumothorax, that tension pneumothorax, we have a chest wall injury, act as a single valve that making the air getting into the chest or the thoracic cavity without getting outside. This is the tension pneumothorax. We have a thoracic wall, for example, injury like rib fracture, for example. In the open pneumothorax, it is less dangerous or least emergent situation than the tension pneumothorax. In open pneumothorax, what happened is that an open pneumothorax forms when air enters the pleural space, but there is not a one-way valve that leads to a tension pneumothorax. These can be spontaneous without any fracture or trauma, especially in tall, thin patients and young patients, most common presentation with open pneumothorax, or secondary to underlying lung pathology or trauma. Patient will usually present with shortness of breath or chest pain. This is the clinical presentation. Physical exam reveal diminished breath sound on the affected side, as well as non-deviated trachea and no jugular vein distension. What should we see in a chest radiograph? X-ray finding on plain film, the pleural line will be seen separated from the chest wall. Let's see here. Here we have the visceral pleural line, and this side is separated from the parietal pleural line because we have this sign which is called the deep sulcus sign, the presence of free air within the costophrenic angle. This is the sulcus and this is the air within it, which is more deeper than this side. This side is more deeper than this. Here we have the label, a collapsed lung in pink color, air-filled pleural space underneath. So it is an emergency. What we should do, we shouldn't request a chest x-ray, no. Immediately placement of a chest tube in the fourth intercostal space at the mid-axillary line is the management of open pneumothorax. So we have here the normal chest radiograph with aeration equal bilaterally. Here the normal side, and this is the left side. The better way to visualize or to learn how to know the pathology or notice the pathology, to compare the both sides, to see the right side first, the normal, the left side. In comparison between them, you can assess the abnormal area. Okay, the main point that the more lucent area over here isn't here. If you trace then well, then you can trace the visceral pleural line and diagnose pneumothorax. This is the open pneumothorax. A quiz for the next session, that if you can, you have to notice this chest x-ray. What is the abnormality in this chest x-ray? Is it normal or abnormal? See you in next session. Good luck.